Thank you for the introduction, and good morning, everyone. I'd like to thank the organizing committee for inviting me to participate in this conference. I'm very happy to be here today to talk about advances in thymidine kinase 2 deficiency, or TK2D. These are my disclosures, and this is the outline of my presentation. I will first introduce TK2 deficiency as a mitochondrial DNA depletion and multiple deletion syndrome. Then I'll talk some about epidemiology of the disease, the phenotypic spectrum of this disorder, the natural history and prognosis. And then I'll talk about some of the emergent biomarkers that can help us to stratify patients and define disease severity. And finally, I'm going to summarize the current evidence of the results of nucleoside therapy, which is the first FDA-approved treatment for this condition. Thymidine kinase 2 enzyme catalyzes the first phosphorylation step of the intramitochondrial pyrimidine deoxynucleosides, deoxycytidine and deoxythymidine within mitochondria as part of the salvage pathway that provides precursors for the mitochondrial DNA synthesis. TK2 deficiency leads to a reduction and alteration of the nucleotide pool, and this produces an alteration of the mtDNA synthesis in the affected tissues. In this graphic, you can see from our cohort of patients that almost all of them have a significant reduction of mtDNA content in the skeletal muscle. Not only patients with very early onset disease, the red dots, but also patients with juvenile and adult onset disease do have a significant reduction of mtDNA levels in the muscle. And as that was already discussed yesterday, these patients not only have this reduction of mtDNA levels, but also they have an accumulation of errors of replication in the form of accumulation of duplications and multiple deletions in the affected tissues. Most patients have this combination, although patients with a very early onset disease, where we have done the muscle biopsy during the first months of life, they do not have these structural alterations, only the profound depletion. And on the contrary, patients with a very late onset disease that started with symptoms after the age of 40 do not have reduction of mtDNA, but the highest accumulation of duplications and multiple deletions. And this occurs mainly in the skeletal muscle, which is the tissue that is more vulnerable to TK2 deficiency. And this is an example from a patient in a case, in an autopsy case study, a patient with childhood onset thymidine kinase 2 deficiency who died from respiratory failure. We analyzed different tissues to assess for the mtDNA content and also the OXPHOS function. And we saw that the tissue that was more affected was the diaphragm, the main respiratory muscle, followed by the quadriceps muscle. The rest of the tissues, mainly the heart was normal, brain was normal, and there was also some reduction in the liver, kidneys, and intestine. So this is a progressive myopathy with an early involvement of the respiratory muscles. Current estimates suggest that there are approximately 1.64 patients per million worldwide, although this is an estimation based just on literature review, not population studies. And there are differences between countries. For example, in our country, TK2 gene is the more frequent nuclear gene involved in mitochondrial diseases, both in adult and pediatric population. We have identified so far more than 60 patients with TK2 deficiency in Spain, and we have identified more than 16 different variants in these patients throughout the country, although there are two variants that are much more frequent in our population and that have some founder effect. And interestingly, one of these variants, that is the more frequent one, is associated with a milder, later onset presentation. And this is the reason why in our country, most patients have a late onset disease. TK2 deficiency manifests as a continuous clinical spectrum. It can start at any age. It progresses at different rates, although in general, the earlier the onset, the more severe and faster the progression. There are some patients with a very early onset disease that may have central nervous system involvement, encephalopathy and epilepsy, but these are rare. Mostly patients develop normally during the first months of life, and then once the disease starts, many times after a mild respiratory infection, they rapidly progress, losing all motor milestones previously achieved, and generally die in few months due to respiratory failure. Patients with a childhood onset or juvenile onset disease do have a progressive muscle weakness with early involvement of the respiratory muscles, and these are the more difficult ones to diagnose since they are very similar to other muscle diseases, to muscular dystrophies. And these patients do have very high levels of CKE, which is rare in other mitochondrial myopathies. There are other patients with a very late onset disease that predominantly have ophthalmoplegia with different degrees of muscle weakness, but in our experience, these patients also die from respiratory complications, and this is also different from other ophthalmoplegia-associated mtDNA maintenance disorders. UCB, that currently holds the license for the development of nucleoside therapy, has built the largest international data set of untreated patients with TK2 deficiency that includes 257 patients. It draws from the literature review, retrospective chart review, and also from the pre-treatment period of the subsequent clinical studies that they have conducted. And of these patients, most of them, almost 200, have an onset of disease of less than 12 years, that are the ones that are more frequently reported. And in fact, the age at onset is generally before the age of 2. The median age at onset of these subgroup of patients is 1.4. And they have analyzed the motor development of the patients and have shown that most patients initially develop normally. Most initially achieve the ability to walk or to sit independently, to hold heads, and to stand before the disease onset. But once the disease starts, subsequently lost these motor milestones previously achieved. 80% of the patients at a median age of 2 years lost at least one motor milestone, and more than 40% of the patients lost 4 or more motor milestones. So there is a regression, a motor regression that occurs quite rapidly. This is an example. The patient I showed you before developed completely normal the first year of life, and he reached this situation in just 2 months. And this rapid progression is a clue for the diagnosis, since it's different from other muscle diseases that start at this age. In these cases, the median age at death is 1.8 years, so it progresses very fast and the mortality risk is very high. In this data set also included 49 patients with a symptom onset after the age of 12, but in these cases, the nature of this study, which was retrospective, prevented to have more detail about the motor performance of adult patients, since these patients do not lose motor milestones. These patients, adult patients with TK2D, are able to walk, are able to even run. Only 30% of the patients lose one motor milestone, that was the ability to run. So this is not a good way to assess the motor performance of patients with late onset TK2D. In fact, the survival in these patients was established as 10 years after the disease onset, but the data is very limited because they didn't find patients reported in literature that have died due to late onset TK2D. So we need to assess the real natural history and phenotype of adults with TK2 deficiency. We need smaller cohorts, but very well characterized, that we were able to follow longitudinally. And we have done this in our center. We are following more than 20 patients with late onset TK2 deficiency, and we have described their phenotype, which is quite homogeneous. These patients have symptoms from exercise intolerance to progressive muscle weakness. And when the muscle weakness is present, the distribution of this weakness is quite characteristic. Involve ocular muscles in all patients, all have ptosis, all have facial weakness, half of the patients have ophthalmoplegia, and they have axial muscle weakness. All patients have this cervical muscle weakness. They are not able to hold the head, and also upper limb distal muscle weakness. Some of them may have dysphagia, although it's mild, but the more important feature of these patients is the early involvement of the respiratory muscles, as we've seen in the autopsy case study. These patients, from the time of diagnosis, they already need mechanical ventilation at night, so they already have respiratory insufficiency. There is a disproportion between the weakness of the diaphragm and the weakness of the skeletal muscle. This is quite unusual. In other muscle diseases and very rare in other mitochondrial myopathies. So it's a clue for the differential diagnosis, but also is a clue for the prognosis, since it's the main cause of morbidity and mortality. As an example, this patient that still is able to run, she already needs mechanical ventilation at night to prevent sudden death due to respiratory arrest. So this is quite unusual, difficult to diagnose, but very important to be able to assess really the severity of TK2 deficiency in adults. We've seen that the progression of the respiratory insufficiency, we quantified it, they decline an 8% per year of the forced vital capacity, which is a very fast progression. So they die due to respiratory failure. We have also investigated some biomarkers to assess disease severity and found that the mtDNA content in the muscle is the strongest one. When we analyze this at the moment of the diagnosis, we've seen that correlates strongly with the age of onset of the disease, but also with the age of onset of the mechanical ventilation. Also, this variant that was milder, associated with a milder phenotype, is also associated with a higher amount of mtDNA content in the muscle. So, very good predictor of the severity of the patient, useful to stratify patients. We have also investigated GDF15, a very sensitive, specific biomarker to assess OXPHOS dysfunction, and we have found that GDF15 correlates strongly and significantly with the age of onset of the disease in TK2 deficiency, but also with the motor performance and with the respiratory involvement. So we think that it's useful to monitor the disease progression and also to be used as an outcome measure in clinical trials. We are also using the muscle MRI to visualize the amount of muscle degeneration in our patients. Muscles, when degenerate, they are substituted by fat, and we can quantify this amount of fat using the fat fraction. The muscle that is more involved in TK2 deficiency is the gluteus maximus muscle, and we've seen that this fat fraction strongly correlates with the motor performance and also with the GDF15 levels. So we can use this muscle MRI to monitor the disease progression, and also in the differential diagnosis, since the distribution of the muscle involvement is different in TK2 deficiency from other muscle conditions with similar clinical characteristics. Now let's move on to the results of the therapy. As has already been mentioned, Dr. Hirano's laboratory a few years ago demonstrated that the oral supplementation with deoxythymidine and deoxycytidine in the knock-in mouse model was able to delay onset of disease and expanded the lifespan of the mice by 2 to 3-fold by activating alternative pathways in the cytosol that were able to restore the nucleotide pool and also the mitochondrial DNA synthesis. And very soon after this achievement, several patients around the world, under the supervision of different physicians, started taking non-GMP nucleosides orally. And in 2017, there were already 16 patients from 5 different countries taking nucleosides under compassionate conditions. 12 patients were from Spain. So we decided to gather all of this information to show the benefits of this new therapy. And the more striking result was that all patients survived more than 3 years after the treatment initiation. Also, patients with this infantile onset rapid progressive disease and high mortality rates, all of these patients are still alive, and some of them have been treated by more than 10 years. And not only survived, but these patients regain motor milestones. This patient on the video, for example, that was a Spanish patient that was treated during the first month after the diagnosis. She regained the ability to walk, the mechanical ventilation was removed, and the feeding support was also removed. So the disease halted, we stopped disease progression, and we were able to recover completely the disease in this patient that is still getting better over time. After this publication, the industry bought the license to develop this new approach and get the regulatory approval. Now, currently, UCB is who holds this license, and they have made the GMP product that is called doxycytine and doxyryptamine, and all patients that were taking the non-GMP nucleosides transitioned to the GMP nucleosides, to doxycytine and doxyryptamine, and over the years they have conducted several studies, retrospective, prospective, and an expanded access program, and they have treated almost 100 patients worldwide. Most of the treated patients have an age of onset of symptoms of less than 12, and many of them an age of symptom onset of less than 2, so the more severe phenotype. And they have compared the outcomes of these treated patients with this data set I showed you before, and they have demonstrated a reduce of the overall risk of death by 87 to 90%. So quite remarkable results. And patients not only survived, but they were able to regain these motor milestones previously lost. 20% regain 4 or more motor milestones, ability to walk, to sit, to stand, and 30% regain at least 2 motor milestones. So this is a very, very good result. And with this data, they have get the approval of FDA, as I will see later. All of this with a very good safety profile. The only treatment-related side effect that is very frequent is a dose-dependent diarrhea. So it's well tolerated, however, and with a very good safety profile. But the approval by the FDA in November 2025, this is the label, is just for patients with an age of onset of symptoms of less than 12 years, because they have used this survival and the regain of motor milestones to prove the benefit of the treatment, and this is not good outcomes for the late onset disease, as we have already seen. However, we have experience treating patients, adult patients with nucleosides, and we know that all patients benefit from this therapy. This is an example of a patient that we published a few years ago. He started with symptoms after the age of 40. He had ophthalmoplegia, facial weakness, axial weakness, respiratory insufficiency. And after more than 4 years of treatment, he has regained the strength of the axial muscles. You can also see it in the expression of the face. Even the ophthalmoplegia has improved. The motor performance using different tests has also improved. The forced vital capacity improved the first years and now is completely stable. And the GDF-15 levels normalized during the first year of treatment. And the muscle MRI, we see that after 4 years of therapy, the progression of the disease has stopped. So very good results also in adult patients. So with this in mind, we wanted to prove that adult patients also benefit from the treatment, and currently we are running an open-label clinical trial in our site in Madrid with the support of UCB that provides us with the doxycytine doxyryptamine, and we have currently included 8 patients, 3 of them the last few months, and we have some results of the first 5 patients treated the first 9 months after treatment initiation. We are using many different parameters to assess the response to the treatment. Some of them we have already proved that they are useful in this specific population. I'm going to show you some of these preliminary results, starting with the biomarkers, with the GDF-15 levels. We know that GDF-15 levels correlate strongly with the severity of the disease, and we know that these patients have high levels of GDF-15 during more than 4 years before the treatment initiation. And after treatment started, in all patients, GDF-15 levels decline significantly in every visit. You can see the trajectory of all the patients, the GDF-15 levels decline, and as a group, this decline reached statistical significance in just 6 months of therapy. In parallel of this decline of the GDF-15 levels, we are seeing clinical improvements, especially in these 3 patients with, where the GDF-15 levels decline the most, that were the more severe patients with lower levels of mtDNA in the skeletal muscle. And we are assessing the motor performance of these patients. We are assessing the strength of the muscle using different scales, such as the MRC strength score, the North Star Ambulatory Assessment, and as you can see, the strength of the muscles in the patients improved very soon after initiation of the therapy and reached statistical significance in 3 months of treatment, both in MRC strength score and the North Star Ambulatory Assessment, and very soon after the disease started. I'm going to show you some examples of these improvements. First, this patient that had this upper limb muscle weakness, you can see that in just 6 months of therapy, she completely regained the strength of the biceps, completely. 6 months, the strength of the biceps is now normal. She wasn't able to get up from the floor without help or using an external support, but after 9 months of treatment, she can do it with self-assistance and easier and faster every visit. In this other patient, we see this upper limb muscle weakness that is present in all the patients with late-onset CK2 deficiency that I have seen, and this was recovered in all patients in 1 month of therapy. So the small muscles in the hand recovered very fast. This other patient that wasn't able to get up from a chair without the use of his arms, after 9 months of therapy, is now able to do it easily. We have many different parameters. We also have respiratory analysis that is also improving, the fatigue, and all patients in different ways have improved from the treatment. So, in conclusion, CK2 deficiency is a very severe disease with a progressive muscle weakness and early involvement of the bulbar and the respiratory muscles in all patients, but especially in those with an age of symptom of less than 12 years. Nucleoside therapy has demonstrated that is generally safe and that is able to reduce the risk of mortality by almost 95% in the more severe presentations. We think that adults also need to be treated because we are seeing meaningful improvements in short periods of time without side effects. And with that, I'd like to thank you all for your attention.